Dr. Johnson, she's an infectious disease specialist at Brigham and Women's Hospital. She's going to address unique risks in pregnancy for women with complex bladder reconstruction. Thank you so much.
Yeah, I can mention that. Hi. So I'm sorry, I don't have slides and I'm a little bit of a stand-in, so I'm apologizing in advance. There was an obstetrician who was supposed to be here to speak with you, who's a close colleague of mine, and we actually have shared a number of patients during their female patients with bladder exstrophy during their pregnancies, and I've co-managed them with her to manage all of their infection-related complications. And then I still manage several of them in the outpatient setting now and through their second pregnancies. So I really have a little bit of a more narrow scope talking about infection here, but it is pretty relevant and it comes up a lot in all of the childhood and adult lifetime, and definitely around the time of fertility. And it has really been my privilege to get to manage those patients. Several very healthy pregnancies and really beautiful babies have come out. So that's really been great. So I just wanted to talk just a little bit about urinary tract infections because this comes up so much in childhood and adulthood. And the first thing that I just wanted to say is that it's just a really exhausting problem in childhood and adulthood. I really take care mainly of adults, but can lead to potentially, complications that can be more medically complicated, like actually needing to be hospitalized, but also really just kind of a constant exhaustion of having to, be in contact with providers if there are new symptoms that come up, waiting for, callbacks and urinary test results and new antibiotic prescriptions and worrying about resistance. And so I think that one of the things that I try to do first off with my patients, whether or not they're pregnant and regardless of the type of urinary tract abnormality that they're dealing with, is to just have a first meeting to talk a little bit about just acknowledging that exhaustion. And that one of the goals that I have in working with patients longitudinally is to try to just kind of figure out like what we're trying to get out of the medical care with their recurrent infections. So the first is to keep out of the hospital, to keep it from any type of dangerous infections. But the second really is actually to try to minimize the impact of recurrent infections on the lifetime on your life, on your daily activities of life. And then those are both still applicable during the time of being pregnant. So trying to set up a system where patients can actually have a lot of autonomy to be able to recognize their own symptoms, have a plan that they can enact without having to actually wait for a callback from a provider, where they have standing orders to, get a urinary tract urinalysis and culture testing if they can get that without ever having to reach out to anyone, and having home supplies of antibiotics that are appropriate for the bacteria that they might have around. To be able to initiate therapy without waiting to hear back from a provider, that type of thing. During pregnancy, I do all of the same things that we do when patients are not pregnant, just with a little bit more close attention and a lot more close follow-up. And so we recognize that when our patients with all different types of urinary tract abnormalities, and especially bladder exstrophy, become pregnant, there is an increased risk of developing urinary tract infections during pregnancy, and they can have an increased risk of having more severe infections that can extend to kidney infections. And those are ones that are potentially dangerous both for the woman and for the fetus, and can result in hospitalization. But with really careful, close monitoring and some of these procedures in place to make sure that patients have, an immediate system by which to reach out to a provider or to enact some things at home, we're really able to do really well at actually managing this, as we have with the patients that I've been managing over at the Brigham over the years. And so I just try to emphasize that, it's going to be a little bit bumpier than it was when you weren't pregnant, and maybe a little bit bumpier than it would be for pregnant women without bladder exstrophy, but we can do it. We can work this all together, and we can have a good result with a healthy pregnancy and healthy baby. Those problems do tend to persist for a couple months. It does kind of bleed over into the postpartum period. We do see persistent increased risk of urinary tract infections even in the early postpartum period, which is kind of a difficult way to spend those first couple of months for a lot of women right after they've had a baby. But again, as long as we have really good access and are working with patients, and that helps. I think the only other thing that I just wanted to mention is that over time, sort of historically in pregnancy in general, and especially in pregnancy for women with any abnormalities of the urinary tract, there has been historically kind of a bent to have a low threshold to put people on like chronic long-term antibiotics as sort of like a preventative mechanism. And we really are learning over time and accumulating the knowledge that in most situations, with fairly rare exceptions, it's not really all that helpful. It really just sort of leads to the development of antibiotic resistance. And so we've really been working towards, a strategy both during pregnancy and when not pregnant, to kind of using antibiotics really only as abortive treatment and only when, we fail with other things that non-antibiotic strategies that we can do. I will say that the patients that I manage with bladder exstrophy who are able to do self-bladder irrigation is incredibly effective, and especially during pregnancy. And that's been really, really helpful for UTI, both prevention and abortive therapy. So I don't know if that was helpful, but that's all I wanted to say.